good morning, everybody. While we're getting seated and arranged here, I just want to, again, thank Governor Markell for his very, very illuminating remarks. I want to thank Belle, not only for an excellent forethought in putting together this event, but also for her very educational slides and her discussion to start us off. What we're going to do now is we're going to turn to state experiences. And as you saw from Belle's first couple of slides, the number of unwanted pregnancies has gone down, and there are a number of states that have been leading in that particular area. And so we're going to hear today from state of Washington, Delaware, and Utah. And we're going to be able to have not only presentations about what's happened in those states, but also a question and answer, which will then be followed by, again, question and answer from the colleagues. Before we get from the audience, well, before we get started, I want to welcome everybody who's here clearly, and everybody who is following us online as well. The format for this particular panel will be: I will introduce each speaker as he or she speaks, and that way that'll give you a chance to sort of reflect on what each speaker has said prior. So let me start off with John Weissman, who is the Secretary of Health for the state of Washington. He was appointed by Governor Jay Inslee in April 2013. Welcome. He's an accomplished transformational leader with more than 22 years of local public health experience, and focuses on whole systems approaches to improving health. John has been passionate about public health since reading a 1983 Time magazine article about disease detectives tracking Legionnaire's disease, toxic shock syndrome, and HIV. And for that was his impetus for entering the profession. He has worked in 4 local public health departments in Washington and Connecticut, and of course now serves as a Washington State Secretary of Health. Thank you very much. Welcome, and we are looking forward to your remarks.
Great. Thank you, Camille, and it's really a pleasure to be here and speaking on this topic with you all. I know one of the things that you often like to start out with is some audience participation, and so I thought I would do that and ask you what you think that is. I think Mark's got, so what is that, Mark? A sports jacket, yes, and it would actually go with this outfit. And that would be back in my condominium in Tacoma, which is why I have come dressed to you in formal West Coast wear, but casual East Coast wear. So if there was any confusion about that, I just wanted to clear things up from the beginning. So with that, in Washington State, over 1/3 of our pregnancies are unplanned. While that is better than the national average of 45%, as you heard earlier, our rate really is still too high. So a few years ago, we launched a multi-agency work group to develop strategies to reduce unintended pregnancy. Now, not anticipating significant new resources at that time, we set a modest goal to decrease the percentage of unintended pregnancies from 38% in 2015 to 32.4% by 2022 for a 15% decrease. Now, to help achieve this decrease, we're employing a mix of strategies, including education, health system changes, and policy changes. So, starting first with education. Our educational strategy is focused on implementing evidence-based comprehensive sex education in our highest risk areas. We are using the Personal Responsibility Education program called PREP and employing that in schools, juvenile detention centers, and community-based organizations like the Boys and Girls Club. Currently, we have resources to implement this in 15 of our 39 counties with the highest teen birth rates. Our next strategy, healthcare systems change, is garnering the majority of our attention. This includes one partnership with Upstream USA and another with the Washington State Hospital Association. The partnership with Upstream, as you've already heard, focuses on solving one specific problem within the healthcare delivery system, ensuring that all women have access to the birth control choice of their choice at a single visit. Upstream has identified 5 barriers to women receiving birth control of their choice in a single visit. And those are a lack of trained providers, lack of screening for pregnancy intention by medical assistants, issues with billing, coding, and stocking of LARCs, clinic workflows that ensure efficient operations for same-day access, and a lack of patient awareness about the types of birth control available or where to access them. Upstream, like all of us, keeps patient choice as a core value within a patient counseling model. The Upstream model has 4 distinct components: training the whole care team about the latest information, contraceptive choices, LARC placement and management, and counseling approaches and skills. The second is quality improvement and technical assistance that is delivered actually across the healthcare system and at each clinic location to truly support the specific changes needed to support the transformations we're looking for. The third being a data-driven reporting to ensure that our interventions are working at each clinic and to make sure that we're having the intended consequences. And the last being consumer marketing to share information about the method availability once we actually have sufficiently trained providers. Upstream Washington, we're proud to have in our state, is providing 4 years of sustainable training and technical assistance to approximately 300 public and private health centers, helping them provide care to a projected reach of over 500,000 Washingtonians. Currently, many Washington health centers don't keep long-acting reversible contraceptives or LARC in stock, and they're not necessarily fully trained to provide them. In fact, 14 out of our 39 counties in the state either have only one site or don't have any publicly funded sites offering LARCs. This requires women to travel long distances or make more than one appointment in order to get the care they choose. Now, the long-term sustainability of Upstream Washington's work in Washington state is possible because of Governor Jay Inslee's policy leadership in areas like enhanced LARC reimbursement for Medicaid and Medicaid expansion. Our second healthcare system partnership is with the Washington State Hospital Association, which is sponsoring the development and implementation of a bundled set of best practice care recommendations for pre-pregnancy, pregnancy, labor management, and postpartum care. This is called the Safe Deliveries Roadmap, and the adoption of these recommendations are being promoted statewide for both public and private care settings. And the bundles have been adopted as part of our healthcare reform in Washington state. Our last strategy is that of policy change. Washington state's policymakers understand the importance of equal access to and affordability of reproductive health care and are putting into law reproductive health care access. In 2017, the legislature passed a bill requiring that any health plan issued or renewed on or after July 1 of 2018 that covers contraceptive drugs must also provide reimbursement for a 12-month refill obtained at one time by the enrollee, and the plan must allow that enrollee to obtain it at the site of their provider's office if available. This increases convenience and reduces chances of missed doses by not requiring the person to head to the pharmacy every month to access birth control or submit a mail order. In 2018, the Reproductive Parity Act addressed affordability and access, and it codifies that health plans offered on or after July 1 of 2019 be required to cover all FDA-approved contraception and prohibits co-pays, deductibles, and cost sharing. And this year, the Reproductive Health Care Act for All requires health plans and student plans beginning in 2021 to cover condoms, screening following a sexual assault, well-person visits, medically necessary services following a sexual assault, prenatal vitamins for pregnant persons, and breast pumps for persons expecting a birth or an adoption. And this expansion, to the question earlier, is coverage regardless of gender or how one identifies their gender. In closing, I have two things. One is our governor's support for this, and I think standing up again for a woman's right for reproductive health at the State of the State address, in which he said, at a time when a woman's health care rights are under attack through our nation, let's leave a legacy that ensures full access to contraception and allows women to chart their own course. That includes access to long-acting reversible contraception and reproductive parity. And I also want to say in closing that the work I have described is not done in isolation. As a public health agency working to achieve health equity, we are committed to the broad work of reproductive justice. This includes things like addressing inequitable impacts of environmental threats to our air, water, food, shelter, clothing, and reproduction, addressing personal security and health, addressing racism, discrimination, social connection, and support, along with self-esteem and bringing the lived experience of the people we serve. I know this is a tall order, and we continually strive to meet it. Thank you very much.
Thank you, Secretary Weissman. And now we're going to hear from Dr. Carol Rattay, who is the Director of the Delaware Division of Public Health. Welcome. She is a board-certified pediatrician and also specializes in preventive medicine. And prior to her appointment, she worked at the Nemours Health and Prevention Services, where since 2004, she led its childhood obesity initiative and efforts to prevent overweight in primary care settings. Dr. Rattay also provided weight management clinical care at the Alfred I. DuPont Hospital for Children in Wilmington, Delaware. Between September 2001 and June 2004, Dr. Rattay served as a senior public health advisor to the Surgeon General and Assistant Secretary of Health in the Office of Disease Prevention and Health Promotion at the Department of Health and Human Services here in Washington, D.C. We're very much looking forward to your remarks. Thank you, Director Rattay.
Thank you so much. It's truly a pleasure to get to be here with all of you today. I feel incredibly fortunate to have the opportunity to do the work I do as the health official for Delaware. And thank you, Governor Markell, for giving me that opportunity. As you can see, I'm very lucky to have been able to serve under Governor Markell and his leadership, and also very fortunate that our now Governor Carney is also very supportive of this initiative. You're going to hear a lot more about upstream, but the work that we have done in Delaware is just clearly not possible without a partnership like the partnership that we have with upstream in our state. And we also have many other wonderful, necessary, great partnerships in the state of Delaware. So kind of as I walk through memory lane with this, our discussions around increasing access to, and at that time we called it LARC, began in 2014 when several of us came together here in Washington, D.C. under a HRSA-sponsored initiative, the COIN initiative, focused on improving birth outcomes. And our Medicaid director was with us, which was really great. And we have, you've already heard from Governor Markell, very high unintended pregnancy rates in the state of Delaware. We also have very high infant mortality and preterm birth rates in the state of Delaware, and have tried a number of approaches, and we've seen some decreases. But given high numbers of poor birth spacing, we started really planting seeds and saying at that collective learning collaborative here in DC that this needs to be one of, if not our highest priorities in the state of Delaware. So we went back to Delaware. Even our Medicaid director was really excited about this. And then a few weeks later, I got an email from the governor saying, with an attachment from that included a proposal from Mark Edwards, and I don't think upstream existed at that time. But the governor said, "Can we do this?" And we came together. I got to meet Mark Edwards shortly thereafter, and I knew immediately this was going to be a great partnership, and we got back to the governor saying, oh, yeah, we can do this, but we're going to need some help. And I also just really want to add at this point, through the next few years, the leadership of our governor in being able to break through barriers was so helpful to us. And in fact, our Governor Markell, I think, did a lot of great things in Delaware, including establishing one of the best trail networks in our state. So as it relates to public health, we made some strides forward. But this was the one where, I had never received weekend calls before from the governor. And he, in the winter of 2015, I would go, so how are we doing? What do we need to do to make progress on this? He was so committed, and it was clear. So Mark and I started taking a Delaware tour, and we met with a number of health providers throughout the state. I think Mark was in Delaware at least 5-6 times over a 6-month period, where we were traveling and really hearing from providers across the state, including Dr. Tilden Burton, who you'll hear from, and others, what they thought about an initiative to increase access to IUDs and implants, and what were the barriers. I also want to add, simultaneously, Liz O'Neill, who worked for our largest birth hospital, also brought together a number of folks, and my guess is it probably was a larger turnout than you expected, where there was way more than 100 people in a room learning about St. Louis and learning about Colorado. And the reason I bring all of this up is there was clearly momentum in our state. People wanted to do this work, but there was no such thing as same-day access at that time. And when Mark and I would talk to people, they were like, we like this idea, but we don't think that's possible. Or we would hear myths and misperceptions like, well, you can't use IUDs with teenagers, or with somebody who's not had a baby, or even from healthcare providers. We were hearing things, and one healthcare provider said, yeah, we think that it would be beneficial to train, APRNs and physicians, but we don't think the whole practice transformation is necessary for us. Interestingly, right around that time, Medicaid had really, creatively looked at how can they increase access to immediate postpartum LARC, and so by using a pharmacy benefit, we were able to increase access to immediate postpartum IUDs and implants, and also through federally qualified health centers, use a pharmacy benefit. But what we were finding was that none of them implemented it. And the reason being, there's more to practice transformation by far than just a policy change. Nonetheless, Mark and I worked on developing our plan, and I like to call it a public health approach because, public health, that's what we call things. But a multifaceted approach, which includes policy change, system change, practice transformation, but also increasing awareness. So, meaning we really wanted women to know about different contraceptive methods, to know the pros and cons of different methods, and also know where to access them. But we wanted to make sure that they had the access before we went out there with that piece. It was also very important in our plan that we built in evaluation, so we knew we knew if we were making progress, and we were learning from our progress along the way. And also we knew from the beginning that we had to think about sustainability. And I'll circle back around to that. Being in public health, state government agency that was still really functioning in the time after the recession, finances were low, staff was stretched very thin, but Mark really convinced me that we had to have this go big or go home kind of approach to this. I kept saying, well, I think we can do this, and he's like, oh no, we got to do this big. And so we did, thanks to Upstream. We did, and we have trained in our state. When I say the we, that's really Upstream, has been in over 100 sites, about 142 sites, reaching nearly 700 clinicians and almost 3,000 staff in our little state. Our state has shy of 1 million people. So a tremendous amount of people. In fact, more than 126,000 women of reproductive age are served annually by clinicians and staff who have now been trained under the Delaware CAN initiative. And I just have to say, in my years as a medical and public health professional, I have never seen an initiative that has had such a dramatic impact on practice change in such a short period of time. As the governor mentioned, in Title 10, our IUD and implant, our LARC usage increased from 13.7% to 31.5% in our family planning clinics for those 20 to 39. And we have a simulated estimated reduction in unintended pregnancies of about 24% in our state. I also was kind of sleuthing around this morning on the way here to see how are we doing on preterm birth rates. And our latest data from 2018 actually show finally a reduction in preterm birth rates, while the rest of the nation is seeing an increase. And we believe, we don't like using annual data because our numbers are so low in Delaware. Nonetheless, this is the first real promising sign around birth outcomes, that we've seen. So you're going to hear more about practice change, but the practice change and the whole practice transformation is so hugely important. But the policy pieces are very important as well. Having Medicaid at the table all along has been incredibly important. So working with federally qualified health centers to carve out IUDs and implants to make them available and affordable and available has been critical. I want to make a mention around immediate postpartum LARC usage because Medicaid was able to tackle that pretty early in our state, as in other states. We've been a part of a learning collaborative run by ASTO, the Association of State and Territorial Health Officials, and learned from really pretty much all states are dealing with not being able to provide immediate postpartum IUDs and implants for privately insured individuals. And that creates a two-tiered system. Now, one of the great policies that was enacted in our state, and I really want to give a shout out to Liz O'Neill, who spearheaded this and spent a lot of time in our legislative hall last year, was really codifying the Affordable Care Act birth control benefits. So now in Delaware State Code, birth control coverage is required with no out-of-pocket cost, as well as a 12-month supply of the pill and over-the-counter emergency contraception, and, this is a big and, mandating private coverage for immediate postpartum LARC. We were the first state to do that, and we're very proud. That was signed into law by our Governor Carney in 2018. And oh, I'm over time. Sorry, I wasn't even looking at you. Okay, very quickly, sustainability was key. And so last week, our House approved a budget that, for the first time in my 10 years in my role, actually puts a line in public health's budget for a mission important initiative like this. The budget line says Delaware can, and through this sustainability effort, we're going to be able to continue to provide contraception for uninsured and underinsured individuals and have staff to continue some of the training as upstream moves on to other states. So thank you so much.
Thank you, Director Atte. Now we're going to hear from Dr. David Turek, who's an associate professor in the University of Utah Department of Obstetrics and Gynecology. He's also a board-certified obstetrics and gynecology and family practice doctor. He received his MD from Tufts University School of Medicine, and his residency training in obstetrics and gynecology was accomplished at the University of Utah, where he stayed on as a faculty member. His areas of clinical interest and expertise include all aspects of women's health care, particularly family planning. Welcome, and thank you.
Thank you very much. And thanks to Bell Sawhill and Brookings for the opportunity, and thanks to the team in Utah that I represent, who none of which what I'm going to tell you about would have happened without them. As a not young OBGYN, I have been present over 10,000 times when women have trusted me to care for them at critical times during pregnancy. I have seen, heard, and felt elation, exhaustion, pain, grief, and plain relief from women undergoing natural childbirth, cesarean sections, abortions, and miscarriages. And from these experiences, I have learned to trust women. A few years ago, I vividly remember walking out of a clinic room in downtown Salt Lake, and I had just placed an IUD for a patient who I knew very well. I had been there when she had come way too close to dying at the birth of her twins, and we had done some pretty unusual things to get her an IUD that she very much wanted, but didn't have insurance for and couldn't afford. And I stood outside of her room thinking, why are we making it so hard for people to plan their families? So I got to work, building a team to expand contraceptive care for the people who are the most underserved in our neighborhood and in our community. And now it is very exciting to share some progress about 2 Utah-based contraceptive initiatives. The Her Salt Lake Contraceptive Initiative began in 2015 as a plan to make IUDs and implants highly effective reversible, or HER, contraceptive methods available to people in Salt Lake without cost. And colleagues helped me realize that it wasn't just about IUDs and implants. Some people just do not want a piece of plastic in their body, and for some people the pill works perfectly well. So the project grew to embrace reproductive justice, the simply decent notion that basic human rights involve 3 principles around reproduction: the human right to have a child, to not have a child, and parent your children in safe and healthy environments. And I nod in appreciation to the women of color led by Loretta Ross and her colleagues who developed the framework, and to the young women who are continuing this work today. Reproductive justice needs to be in this conversation about increasing opportunity through access to family planning. We do our best as healthcare providers when we give non-directive counseling and offer the full range of methods, and when we don't create obstacles for removing IUDs and implants, and we don't over-encourage their use. So Her Salt Lake changed, and Her became emphatic support for women's autonomy to access all methods, not just the highly effective ones. And in our community, there's clearly one provider who provides the most care to women in need, the best contraceptive care at the least cost, and that's Planned Parenthood, so we partnered with them. And in March 2016, anyone coming to one of their 4 clinics in Salt Lake County could walk out with any method of contraception they desired without cost, and clients could return as many times as they wanted over the next 3 years to get the next method if that was required. And we served 7,402 people over the course of a year, and we enrolled 4,425 in a 3-year study to rigorously assess how people made decisions about contraception and how these choices influenced reproductive autonomy, wellness, sexual satisfaction, as well as health, education, and financial outcomes. This graph tells the story of what happened with the contraceptive method mix during the course of Her Salt Lake. This red vertical line represents March 2016 when we shifted to no-cost contraceptive care. The purple line at the bottom that ascends is the proportion of people who walked out of the clinics with IUDs and implants over time. The aqua line at the top, that starts at the top and drops, represents the proportion of people who left with pills, patch, ring, and Depo-Provera shots. At the baseline, about 1 in 5 people walked out with an IUD or an implant, and that rose to 1 in 3. Even more importantly, this occurred in a welcoming place where each client could get the contraceptive method that she decided worked best for her, and people knew they could come back and get the next best thing if the first choice didn't work. So Her Salt Lake provided us with some key takeaways. These results demonstrated there was real demand to expand services, and the data were used to support a family planning Medicaid waiver, legislation sponsored by Republican Utah House Representative Ray Ward. And now more than ever, rational, disciplined, dedicated public servants like Ray Ward are a way too rare and highly cherished commodity. We also learned the importance of building relationships with elected officials and coalitions with advocacy groups. And finally, Her Salt Lake created a platform to expand services statewide. And that is where our second contraceptive initiative, Family Planning Elevated, comes in. Family Planning Elevated applies what we learned at Planned Parenthood clinics in Salt Lake to community health centers across the state so they could make an additive contribution. Family Planning Elevated addresses 3 Ps. For patients, it means that people with an income below 250% of the federal poverty level can get the contraceptive method they want at no cost at participating clinics, and that includes undocumented immigrants who are not included in Medicaid. Secondly, FPE trains community health center providers and staff so that they can offer the full range of methods. And third, Family Planning Elevated assists policymakers in passing evidence-based legislation. So between these 2 programs, we're on track to serve 28,000 people with person-centered care that promotes their autonomy. And of course, this will save Utah taxpayers money, a lot, more than $28 million through Medicaid savings alone. And this is a benefit, but not the only one and not the most significant. Together, these 2 projects, Her Salt Lake and Family Planning Elevated, create a platform for a statewide network to maximize contraceptive coverage that allows federally qualified community health centers to make a contribution on top of the one that allows Planned Parenthood to provide care for 47,000 people a year in our state. Her Salt Lake and Family Planning Elevated are unique among contraceptive access projects. We've used our bold optimism to gather a broad base of support from community members, pharmaceutical companies, local and national foundations, the NIH, and the Society of Family Planning. We've also focused on reproductive autonomy, and we had a specific policy target at the beginning, Medicaid expansion. So as an OBGYN, I trust women to make the best decisions about sex and reproduction, and I'm not intoxicated by the idea that IUDs and implants alone are going to fix poverty. Contraception is important, but IUDs don't improve opportunities for children in Utah when they're living in this state that spends 50th among states on per pupil expenses on education, and contraceptive implants don't improve opportunities for their moms when they're living in the state with the greatest gender-based wage gap. We have no more time for polarization along the pro-life, pro-choice battle lines. It's time to collectively embrace reproductive justice and focus on opportunity, which includes the opportunity for safe pregnancy care and infertility treatment and abortion access, educational opportunities, and the opportunity to live without police violence and environmental injustice. We have the power to shift the ugly, mean-spirited shaming and blaming we are seeing across the country with an example from Utah that demonstrates what real pro-women, pro-family, pro-autonomy care and policy look like. Thanks.
Thank you, Dr. Turek. I want us to give our panelists who have been absolutely stellar a really warm round of applause. So I will be asking the panelists a few questions before we get into audience Q&A. And so to start off, what I'm going to say is that we've heard some very interesting reflections and perspectives on how to provide access, information, and better training through an equity lens in order to promote family planning choices. So I'm going to just any of you can answer this, or there are going to be other questions, so you're welcome to forego this one as well. But given the policy landscape currently for family planning and the experiences your offices have had, What additional scope is there for states to play a leading role in this area?
I'll go ahead and jump in. I think states have a very important role to play in women having access to the full range of contraceptive methods. That being said, I think it's also important that when we think about access to contraception, we are thinking it in the context of, a broader range of health improvements, whether it's substance abuse or mental health access to support for social determinants of health, et cetera. But within that context, I think it's important for states to be thinking about a multifaceted approach, as I called it, the public health approach, to ensuring that that all women have access to the full range of contraception. We certainly have a role to play in supporting policies that ensure that access is there, but also in many of our states, in our divisions or departments of health, we oversee the Title X program. For our state, we've been relying heavily on the Title X program for the work we're doing, and certainly for the sustainability efforts. So it's important that we maximize Title X. And then finally, I think that states have a role to also invest in reproductive health care for women.
Thank you.
I think I would add that states have this particular power as well to be either the first mover in a state around setting policy and thinking about what it is, what our influence is with the public funding we have. And so one of those certainly is around healthcare and healthcare reform and the purchasing power we have with Medicaid, with public employee benefits, and setting that stage. And so to the extent that through policy and through what it is we choose to purchase, what services, is incredibly powerful. And I had mentioned the Safe Deliveries Roadmap from the Hospital Association and the sort of suite of things in their bundle. If you look at the pre-pregnancy care recommendations, for example, they have things from hypertension, diabetes, sexually transmitted disease, violence and abuse, screening, but as well as things like toxic environmental exposure. So exposures to toxins at home or in the community in which they might live. So through those kind of efforts, I think we in states can be incubators for trying new policies, which is certainly what we've heard today with all of the upstream work. I mean, Washington's benefiting from all of your work in Delaware. So I think that's a really important place that states have in the ability to experiment and think about what it is we purchase with our budgets and how we want to change things, and then hopefully drive also the private sector into the directions where we find evidence base.
Thank you, Secretary Weissman. David?
And in places where the leaders don't lead, sometimes the people need to. So I think it's been pointed out several times that in the current, with the current administration, really solutions do need to come at the state level and preservation as well. But our state didn't expand Medicaid until 2019 and only did so when there was a ballot initiative. And then the legislature eviscerated that, cut the federal poverty level limit on it, and added some additional restrictions. So our approach in Utah as researchers and clinicians has been to not just wait around for some opportunity to come along that we could fill, but to actually get out ahead of it and demonstrate what could be done, and then encourage legislators to follow and address the demand once we've established it.
You know, I'm sure we could spend a whole afternoon on that. And also these excellent, really excellent suggestions about, making sure that we maximize Title X, really optimizing what services we buy, et cetera, at the state level, and of course, taking the bull by the horns and just going for it if there isn't a lot of state action at the top level. So I have a second question, which is around the tensions that this kind of work tends to incur. And some of them are political, some of them are policy, some of them are actually around transforming practice, clinical practice. So I want you to reflect on those tensions. And Dr. Turk, we'll start with you.
Yeah, I might be living in a little more tense environment than my colleagues. Obviously the main tension in a conservative state like Utah is about abortion. And there is just no denying it. There is also no denying that there are imperfections. Humans are complicated, and we are imperfect about picking our sexual partners, not myself, but...
All except for you.
Yeah, right. Imperfect about, I'm headed for my 25th anniversary with my wife after this, so, so there are imperfections in partner choice, there's imperfections in contraceptive methods. None of these things work perfectly, and there's imperfection in biology. So we need to get to a place where we can just acknowledge that abortion will never go away. It will exist. It has existed in every society forever. And from that point, we got to also understand it's incredibly common. Over 1 million women a year have this in the United States, and most of them are mothers. And that is not something we hear or talk about. So I think we can, once we acknowledge that, we can try to find some actionable common ground, and I think we've heard a bunch about that today. And people being able to plan their families is a critical part of that. So let's acknowledge the tension and then move past it to the place where we can work together and actually do some good.
Great, thank you. Others?
Reproductive coercion has come up several times today, and I want to recognize how important it is that we are sensitive to this as an issue, that we acknowledge the dangerous history of reproductive oppression and coercion across the country targeted at women and people of color and low-income individuals. All along, we have, with our Delaware Can initiative, focused on all methods for all women, and the transformation that has taken place in the practice has been supportive of all methods, all payer types, and ensuring that there's no wrong door for any women, and that all women across the state have access. And in fact, during a period of time, all methods were free across our state for any woman. And also, there has been a real intentional effort to ensure that there are no barriers to removing IUDs and implants, which we feel is very important as well. One of the things that our upstream partners have done is surveying women as they depart or after their visits, and finding that 99% of women have indicated that they have either made their own choices about contraception or shared decision-making with their providers is very important to us. We think that it's critical that we continue to strive for all women feeling empowered regardless of their insurance type. That being said, that two-tiered system I mentioned about immediate postpartum and private insurers not covering it is problematic.
Thank you.
think agree with everything my colleagues have said, and I would just add, I think the tensions around uncertainty with the federal government and the rules and regulations around these programs is really high right now. In Washington state, actually, voters way back in 1991 passed an initiative, which is state law, that said every individual will have the fundamental right of privacy with respect to personal reproductive decisions, that every woman will have the right to choose or refuse to have an abortion, and that the state shall not deny or interfere with a woman's right to choose abortion. We won't discriminate against those rights through regulation of benefits, facilities, services, or information. And so we find ourselves right now in Washington state at this tension with the current Title X rules and the Ninth Circuit, as was just mentioned, that if that holds, we will be forced to withdraw from the Title X program because it will be against state law for us to participate. And again, I think the health care, the reproductive health care that this purchases, the state puts in something like $9 million a year in our own state funding and about $4 million in federal funding, just again sort of limits access. It hurts the folks who have the least access, can least afford this, and it just simply isn't right. So that tension of patients who are in Washington, well, what do we do? Is this like safe to go to a provider or not? Where do we stand? Is something that I think we can't underestimate. And once again, these are populations who have been historically traumatized, who have been discriminated against, and they see it, I think, playing it out again in their governments.
Thank you very much. You have all started your presentations by talking about the statistics that sort of drove the efforts behind improved family planning and reproductive services. One of the questions I have for you is around navigating the policy space. So first you start from a position of, okay, here are the facts, and the facts are not what we would like them to be. And now we're going to move forward with some policies and programmatic approaches. As you have done that, the family planning landscape keeps changing. It changes at the state level. As you mentioned, it changes at the federal level. Have you made any changes to the ways in which you are rolling out programs as those changes have occurred at the policy level, both at the state and the federal level?
I guess I would say we're looking at what it is we feel we need to put in state laws to protect what's already there, such that if the federal government does change either their rules or laws or the ACA, that at least in Washington state, we've got in state law our expectations. So that's definitely been a change, as well as I think just the time and effort to fight lawsuits around this. Not to get political about this, but we're trying to protect reproductive health care in this country, and it's under attack. And so we're having to think about what we do along those lines. And some of that is, how do we assure what's there now is going to stay in our state regardless of what happens.
Great, thank you very much. Director Rattay?
I'll add to what John said. It's the same for us. We've been working to preserve, for example, what's in the Affordable Care Act, and the new Title X rules, quite frankly, are devastating to us and to the work that we have been doing. It's beyond disruptive to the system that we have been building with providers, and even just who it is that can do counseling. Well, in our initiative in our state, medical assistants and nurses are doing a lot of the counseling. So the new Title X rules are very problematic for that. So the unacceptable restraints on healthcare providers with the new Title X rules are really quite devastating to the program that we've been working so hard to build.
Okay, thank you. And Dr. Turek?
No policy by itself just
increases access or care. So, it's interesting to hear that you all are, I think, working from a somewhat defensive posture from the national effects, and obviously we are too. But I think it's also important to acknowledge that a policy by itself doesn't create the opportunity. It's got to involve some hands-on and interactions for actual care delivery to occur and differences to be made. And it just, so much comes down to, like, this is a solvable problem. This is not some, unsolvable thing. It's very simple, and it's about resource allocation. And Title X provides this incredible example about that. So if you look at the national Title X expenditures for 2019 for all the states, it's $260 million. A single state, Mississippi, spends more than that on just delivering pregnancy care for people who have Medicaid and had unplanned births. And it's not a totally fair comparator, but it gives you an idea of what the balance of resource allocation is.
Great, thank you very much. We are now going to move to Q&A from the audience. So the way I tend to do this is we'll take about 3 questions at a time, and then you're free to answer one, all, it's up to you. And then we'll also be able to accommodate more questions. So our first question, we have a gentleman in purple here, a gentleman with a red checked shirt, and this young lady in the leopard cheetah skin jacket. There we go.
Hi, I'm Mark Hathaway in the purple shirt from Washington, D.C. Unfortunately, not a state yet, but perhaps someday. But thank you to everyone for the leadership and the work on this. This is fantastic. Lots and lots of great things. I'm curious about if one of you might address the issue of, we know that the lower social economic quintiles have the highest rates of everything terrible: smoking, obesity, access to good food, access to family planning services. So I'm wondering if you can talk a little bit about how you've been able to draw them into clinic care where there's mistrust and men don't understand that when you have sex you might get pregnant. Women perhaps understand it better. But at the same time, even once you recognize that, getting into a clinic and getting access to care or making that step to get to a clinic setting is a hurdle. And so I'm wondering if you can talk a little bit about how you've addressed that to getting folks over that hurdle, getting to a site to get care.
Great, thanks, Mark. I'll take our second question here.
Can you expand, can the panel expand on their comments regarding the revisions to Title X and the impact that's having on the programs?
Thank you.
Kay Oshel, I'm a retired federal employee. My question is for Dr. Turek, and I just wondered whether the LDS leadership had a position or a reaction to your 2 programs you mentioned.
Thank you. Okay, so we have a first question on how do you get folks who do not trust medical care into clinics? And then a second question on what exactly are the revisions to Title X? And then, of course, the third question for Dr. Turek on the LDS reaction to your work. Okay, Dr. Rattay.
So we can choose whichever question?
Or all.
So the first question is a great question. And the barriers that we understand include lack of access, lack of affordability, and lack of awareness. And so certainly in our efforts include tackling all of those. So whether it's the policy barriers or for our all methods free approach, ensuring that women can afford access is important, but also making sure that our providers that are serving them have transform their practice so that they can provide the all methods free same day access has been critical. But the social marketing work that we've been doing across socioeconomic classes, I mean, certainly increasing awareness and really empowering women and telling them kind of how do you access these services has been really important to reach women.
Great, thank you. Dr. Turek?
I might tag onto that. We've basically gone to where people are, and then tried to augment that with a media campaign. So I didn't get to talk about that, but that was an aspect of what we did in her Salt Lake. And we learned some things there, and we'll try to improve upon them for Family Planning Elevated with a media campaign that's currently in development.
Great, thank you. Did you want to answer the other question?
Please. So, obviously the LDS Church yields some considerable power at the legislature in Utah, and the church, to my understanding, is supportive of people planning their families, and that's the actionable common ground. And people vote with their feet, the LDS membership. And I can remember a very specific patient I saw at Planned Parenthood who I walked into the room, and it started to, I knew she was there for an IUD insertion, and I started to talk to her about that. And she said, oh, listen, I know all about this. I just had my 6th kid, and this will be my 6th IUD, and they've all been spaced 3 years apart. And this is not like an incredibly uncommon thing. People have big families, but they have spaced families, and it represents their values. So I think that's, again, that's the place where we can meet people and have meaningful discussions.
Great, thank you, Secretary Weissman.
I would just add on the lower socioeconomic piece, I think, and again, this is sort of broader, I think, healthcare, what we're working on and needing to do is one, hiring people who actually look like the community we serve, who are from the community we serve, who speak the language of the community being served, both in terms of the sort of professional staff as well as models looking at community health workers, who are those trusted folks from the community who can help folks navigate very complex systems, and again, speak their language, come from their culture, and I think those are important in terms of healthcare systems competency in being able to provide culturally appropriate and relevant health care. So I would just add that piece. On the Title X impacts, so some of the things that are happening is that the rules immediately actually prevent a healthcare provider in a Title X program from talking about abortion. If a patient wants an abortion, they cannot give a list of providers that are identified as someone who might provide an abortion. They have to give a list of actually primary care providers, and they can't indicate whether they provide abortions or not, and they can actually choose to give a list of providers that they know nobody provides abortions. So that's what we call the gag rule, and really very devastating, and frankly, we believe interferes with the provider and patient relationship and full medical appropriate information, and is really harmful to again, if we're talking patient-centered, that is not at all a patient-centered approach. And then there are provisions that go into effect later that require things like a physical wall separation in a provider who might provide both abortions and other contraceptive care, that they have to be physically separate sites, separate entrances. And so those kinds of things make it incredibly difficult to operate a program that is fully inclusive.
Thank you.
Yeah.
Yeah,
I was going to say, in our state, Planned Parenthood is the lone Title X grantee, and has been for a very long time, and has done a phenomenal job on an incredibly tight budget. And they've committed to continuing to provide the services and planned for this, and we're prepared and have, we'll use funding from other sources to get it done until this can be clarified.
Great, thank you. You know, I hate to do this, but it looks like we are running out of time. So what I wanted to do was invite each of our panelists to give us one statement about one thing we should remember as we think about family planning and family reproductive services in this policy environment. And I'm going to start with you, David.
How much time do we have? You know, I sincerely hope that we're at the nadir of civility on discussions of sexual and reproductive health in our country. And I think it would be really extraordinary if sane policy, rational policy from a very conservative state that respected people's autonomy served as an example. And, you know, let me be frank here. Utah is sane. Like, that's crazy.
Director Ate?
I think it's important that we do keep our eye on policy solutions, especially in this complicated time. There's definitely things that states can do. Again, the Medicaid policy opportunities, for example, with federally qualified health centers and ensuring that there are carve-outs or support for all methods, whether in the clinic as well as that methods are available in birth hospitals, is certainly work that we can continue doing at the state level.
Thank you. And Secretary Weissman?
I would again, I think, emphasize that states are this place where we can experiment and try things and learn from each other, and that's incredibly important, as are local communities, frankly, in this work. And I think the last thing would be that this work is not in isolation of the larger context of societies, of the social determinants of health, of the historical traumas, racism, discrimination, and that certainly as a public health agency, it's my responsibility to look at that broad picture and work with partners on that, and to work, frankly, with community-based organizations who know the best.
Great, thank you. You all have given us a lot of food for thought. Please join me in giving them a very warm round of applause.
Thanks for watching. Be sure to like and subscribe for more videos from Brookings.